All right, hello. Welcome all to the first April session of the Virtual Learning Collaborative made possible in partnership with the CDC's Division of Viral Hepatitis. My name is Zakia Grubbs, and I'm a manager on the hepatitis team at NASDAQ. Today's topic is a recently released resource called the Hepatitis C Telehealth Toolkit, developed in collaboration with the New York State Department of Health, AIDS Institute, Bureau of Hepatitis Healthcare and Epidemiology, the New York City Department of Health and Mental Hygiene Viral Hepatitis Program, and the New York State Office of Addiction Services and Supports, OASSAS. Joining us today are our speakers, Colleen Flanigan, Director, Bureau of Hepatitis Healthcare and Epidemiology, New York State Department of Health, Lauren Walker, Program Director, Hepatitis C and Drug User Health Education and Training Institute for Advanced Medicine with the Mount Sinai Health System, and Abigail Hunter, Clinical Program Manager, Mount Sinai Health System, Vocal NY, and Sinai Cares Program, and our moderator, John Stockton, Adult Viral Hepatitis Prevention Coordinator with the Office of Infectious Disease, Division of Disease Control and Health Statistics at the Washington State Department of Health. The format for today's session is as follows. We will begin with presentations, followed by a Q&A and discussion facilitated by John. Feel free to use the chat to introduce yourselves and jurisdiction and for your questions. With that, I will hand it over to Colleen.
Thank you so much, Zakia, and thanks so much to NASDAQ for having us here today to talk about the Hepatitis C Telehealth Toolkit. I want to thank my colleagues at the Clinical Education Initiative, and it's really great to be here today to share this toolkit. So just really briefly, I think the one thing that came out of COVID, the one good thing that may have come out of COVID is providers and clients and the ability to use telehealth. And so we've been using telehealth in a number of different ways here in New York State. And our work around hepatitis C, I feel like telehealth is one of those other tools in our toolkit. And so we have been specifically using telehealth to build capacity in high-risk settings. And those settings include substance use disorder treatment programs, including opioid use disorder treatment programs, syringe service programs, for example. So programs that do not naturally have capacity to provide hepatitis C treatment or any other clinical services for that matter. And so telehealth allows us to expand capacity and access to hepatitis C treatment in settings serving populations most likely to be living with hepatitis C. And so, for example, in New York State, we have worked with the New York State Office of Addiction Services and Supports, our OASIS programs, and the addiction treatment centers that are run by New York State OASIS. On a telehealth collaborative. And so we joined our addiction treatment centers and hepatitis C care and treatment providers that are funded by the New York State Department of Health to provide hepatitis C treatment and wraparound services. And we introduced the programs to each other as a way to build a relationship with clients in the ATC. So for example, if you have an individual who is living in a county where there is an ATC and a hepatitis C provider, a telehealth visit could happen before the individual is released from the addiction treatment center back out into the community. So that telehealth visit is used to build the relationship with the Hep C provider, to do some introductions, let the individual know, I am the provider, I will be providing treatment for you when you get released from the addiction treatment center. So the telehealth visit is more used for that meet and greet type of visit. Some of our programs have taken it a step further, and the Hep C provider will be the ordering provider to draw pre-treatment labs. So getting those pre-treatment labs out of the way for the client in the ATC, so that when they do that first visit, they can have more of a meaningful visit with the client and know what they're going to expect on that first visit when they get released out, back out into the community. We've also had programs that use telehealth for the full course of treatment. And that is something that is explained very nicely in the telehealth toolkit. If we're going to eliminate Hep C, we need to be innovative. We need to use all of the tools in our toolkit, and telehealth does serve as one of those tools. So we're really excited to share with you the telehealth toolkit. So thank you so much, and I'm going to turn it over to Lauren Walker.
Thanks so much, Colleen, and echoing thanks to NASDAD for inviting us to be here today to speak with you. It's a very exciting initiative. My name is Lauren Walker. I was already introduced. I'll be joined by my colleague, Abby Hunter, in just a few moments here. So I want to start with kind of this broad overview of how the toolkit came to be. We're going to start in the top right-hand corner here. This idea was hatched really in March 2022 at the New York State Hepatitis C Clinical Education Collaborative meeting. I'll get into the details about that collaborative in just a moment. CEI shared details for a webinar we were hosting in June of last year featuring Dr. Andy Talal, and that kind of worked its way into our discussion of needing this resource and actually deciding to develop it. CEI took a lead in the process of developing. We really kind of served as a main manager of how all of this fit together. We started with identifying relevant tools and materials, resources that we already had on hand, and we agreed to use a 2020 document titled Integration of Hepatitis C Telemedicine at Substance Use Treatment Programs, an Implementation Guide as our framework. We also decided to broaden the focus of that document beyond substance use disorder treatment programs. At the same time, we worked to develop a working group of members of the collaborative who were available to really support the development of this toolkit. Our working group met monthly. We did have ad hoc meetings in between as needed, but really kept up the momentum with a standing meeting that happened once a month. Again, CEI really led this process. I think it was integral to have a single point person or point organization take a lead and manage everything. But I will say that our strongest resource was definitely the expertise of all of our technical working group members. Everyone brought something to the table, whether it was actual clinical implementation or academic research, and we really couldn't have created the useful and practical guide that we were able to without everyone's support. I think it's important to mention also here that funding was not available to support the development of the toolkit, but it really fit within the mission and the work that a lot of us were already doing. So we took it on as kind of a side project and are very happy to be able to share it with you. So kind of scooting down the line here, we formally introduced the toolkit on December 13th of last year with a webinar from Abby Hunter. I will share links, just a quick shameless plug for everyone who's with us today. Both of those sessions are recorded and available on CEI's website with CE credit. So if you're interested in seeing either the initial presentation by Dr. Talal or Abby's presentation, you will be able to do that later this afternoon. And finally, here we are at the kind of bottom of my map. We are disseminating and marketing the toolkit. It lives on the CEI website, and there's a link in the bottom right-hand corner of your screen. And you can also access it by clicking on the QR code. So I mentioned the New York Hepatitis Clinical Education Collaborative. Not all of you, I assume, are familiar with us. So we are a small group. We're made up of the Empire Liver Foundation, Mount Sinai Health System, the New York City Department of Health and Mental Hygiene, and the New York State Department of Health AIDS Institute Bureau of Hepatitis Healthcare and Epidemiology. We meet monthly and talk a lot about hepatitis. I think one of our main goals is just making sure that we're not duplicating efforts, and we're really working together to educate people throughout the state in both Hep C and hepatitis B, with a large focus on Hep C elimination. I feel like I'm very likely speaking to the choir here, but this slide really shows what we used to create the toolkit, what really drove us to create this resource. We all know there's this huge treatment divide with Hep C. We have medications that work, and we continue to see increases in infections. And so this tool, as Colleen mentioned, is something you can have in your toolbox that allows you to expand resources and services beyond the traditional healthcare setting. This is just a quick screenshot of the document that we used as a foundation. This was developed in 2020, and I would be remiss to not mention the fact that one of our working group members was both an author of this guide, Dr. Andy Talal, and he also served as a principal investigator for a patient-centered outcomes research institute, or PCORI study, that focused on comparing ways to provide hepatitis C treatment for people who take methadone. And he was able to share real-life best practices and learnings from that study that we then incorporated into the toolkit. A quick thank you to everyone. I know there was an acknowledgement at the beginning, but there were several people, several organizations that really participated in developing the toolkit along with CEI. As I mentioned, we have Drs. Andy Talal and Arpan Daria, both hail from the Jacobs School of Medicine and Biomedical Services at the University at Buffalo. We worked very closely with both First Al Shelton and Nadine Kayla Murphy from the City Department of Health and Mental Hygiene, Colleen Flanigan, who you met earlier, as well as Caitlin Miller-Fazioli, Kate Bliss, and Ron Bass from the New York State Department of Health AIDS Institute, Dr. Kelly Ramsey from OASAS, Dr. Jeff Weiss from the REACH program at Mount Sinai, Laura Shannon from Sunriver Health, and then without further ado, I believe I'm passing things off here to Abby Hunter from Bocal, New York, to share a little bit about the practical implementation of the toolkit, what it looks like in real life, and how you can actually use it in your clinical practices.
Thank you, Lauren, for that very thorough overview, mentioning everybody and talking about the collaboration that created this toolkit. You can go to the next slide, please. So the toolkit is really a how-to or a guide. It's not something, hopefully, that's just left on a shelf. It is something that we really want people to use to be able to implement telehealth for hepatitis C treatment. And I'm going to go over both the traditional and non-traditional settings. And in my work, I've done telehealth in a variety of different ways and through all the different models that are in the toolkit. And so we will review those. Mix and match approach. We're really hoping that more settings will be utilized to be able to provide hepatitis C screening for sure, and then also treatment. So these are some of the settings that where currently it is available, but also there could be obviously an expansion. So both screening, confirming the viral load, treatment, and follow-up. And then when we say specialists, it used to be more traditionally hepatologists, but obviously now we know that PAs, NPs, primary care providers, pretty much anyone with minimal training can provide hepatitis C treatment. And I should say I'm a nurse practitioner. The other staff that are very vital to making these, collaborations work are the people that are located at some of the facilities. So it could be the drug and alcohol providers, so the counselors, it could be peer support workers, patient navigators. These are the people that bring together the prescribers, the people that are doing the treatment, and the participants who need the treatment. Go to the next slide. So what are the models? Well, we kind of, scratched our head trying to figure out models that explain exactly what we're doing. They're flexible and obviously adaptable. And sometimes with treating one person, I've used more than one model because there are times where the person might be out in the street, or there might be another time where the person is actually at their opioid treatment program, that same person. So depending on the visit, I might see them at either one of those places. So the Tele-Harm Reduction model, might use an outreach model. The facilitated telehealth with on-site clinician might be somewhere like an opioid treatment program. And then a facilitated telehealth without an on-site clinician might be somewhere like a rehab or a detox where you don't have an on-site clinician. Go ahead. Yeah. So key staff, I mentioned it before. It's vital in order to get this work done that you have folks who are doing all the, what I call the glue work. So who are these people? They have several titles depending on how your organization might work. A lot of these people do this, similar work, but might have different names. So care coordinators. So those people are really assisting the clinical staff in interacting with the person that requires Hep C treatment and with the prescriber or the provider. And they are in some ways the people that get the person ready for treatment. So, obviously there's competing priorities, housing issues, treatment issues for addiction, et cetera. And some of those issues might need to be addressed before we can even contemplate providing Hep C treatment. Often a care coordinator can be a peer or a peer navigator, which is the second box here. Very important. That's someone with lived experience, not necessarily Hep C lived experience, but substance use or homeless experience, because often those people will, be able to relate, and also some of the information might get received to the navigator rather than the provider. So as a provider, I might find out something from a peer navigator that the person with Hep C might not tell me, and that might be vital for the care. So very important that we have people with lived experience involved in this process. And then finally, you have the telehealth provider. And as I mentioned, this person does not need to be a hepatologist. They just need minimal training, which CEI can assist with. And then they can be a hepatitis C provider. Next slide. Okay, so let's look a little more detail here at the Tele-Harm Reduction model. I already hinted at it a little bit. So I'm a Mount Sinai nurse practitioner, but I'm affiliated with Vocal New York, which is a syringe services program, amongst other things. We do outreach, a peer-delivered syringe exchange outreach, and at the same time, we partner to do hepatitis C treatment out in the field. So our peer navigators might identify people who have Hep C out in the field. These people might never step foot into any brick and mortar facility. They might never come to Vocal, but I have treated people who have actually never met in person and have only met them through my peer navigators who connect us to be able to provide treatment. So this would be the Tele-Harm Reduction model, where it's very low threshold. The person might get brought to a LabCorp or another type of lab to be able to conduct blood work, but they don't actually have to come to a traditional clinic to be able to get treated. And the medication will also be brought to them at that outreach setting. And this could be expanded to shelters, soup kitchens, other harm reduction agencies, anywhere that's low threshold and where you're going to find people that are out of care, but in facilities, in city-run facilities, other facilities, and are there, but are underserved. And so that's the Tele-Harm. This is a little bit about Vocal New York. I mentioned the syringe services program. It's more than that. They also have a very large organizing arm and a big footprint in terms of doing a lot of good work around changing laws having to do with mass incarceration, HIV, et cetera. You can see the mission statement there. But some of the services that Vocal New York offers, again, the peer-delivered syringe exchange outreach, where we partner to do Hep C screening. Healthcare and wellness program, that's the program I'm part of. That program is the one that will assist people with getting insurance if they don't have it. And care coordination, and also get them ready to accept treatment for hepatitis C. We also have a peer job training program, overdose prevention. We have an on-site syringe exchange, which does not go out in the field, and care coordination. Okay, so let's take a quick look at the workflow. I feel like this crowd is probably like a nuts and bolts, like how do we do this? So we're hoping that this will give an idea of like how this actually happens. So with the Tele-Harm Reduction workflow, the first point of contact is an outreach in the field. And so a rapid antibody test that's done very quickly, 20 minutes, finger stick, is conducted on outreach. If that is positive, then we do the dry blood spot. That will tell us a binary yes viral load, no viral load. It won't give us an amount, but it will tell us clearly if the person, has a viral load. We have to send off the dry blood spot to a lab to get it checked. And then we make contact with that person, make sure we can reach them so that we do the next step too, where we deliver results. That can be on outreach or it can be in the office once the DBS comes back. If they are in fact DBS positive, then we're very quick to offer services. What do you need? You don't have health insurance? We can connect you with health insurance. You need some other assistance? You're not ready to get treated? Then let's talk about what your needs are. And we do that through the SDH, which is, it just went out of my head what it means.
Social determinants of health.
Thank you. Social determinants of health are assessed. Thank you, Lauren. I knew you would fill in. So that is just looking at, obviously, what are the other needs that might be more important and need to be addressed before we can assess or work on the hepatitis C treatment. If they're ready to go, we get the health insurance, they are eager to get treated, et cetera. We'll do the first telehealth visit. Again, that can be done on outreach with the peer navigator, could be with the person out in outreach. If the person has a phone themselves, then I call them directly and do the telehealth visit right with their phone in the comfort of wherever they are, in their shelter, in someone else's house they're staying in, etc. We do provide incentives. We are very fortunate to be part of the Innovative Models Grant supported by the New York State Department of Health. So we do have incentives and they are provided throughout the treatment process. I will say incentives are very nice and I love being able to provide them, but most people really want to get treated even without the incentives. The incentives are kind of the cherry on top. The participant might be brought to a LabCorp or another facility to get their lab work done. If syringe services or another low threshold program has its own clinic, then obviously the blood work can be done on site. The medication is ordered. Treatment initiation can occur if you have a clinic, either in person or via telehealth. And that can be, again, with or without peer assistance. So the person has their own phone or we provide them a phone, which we do in our program, then we can do direct with them. We can do direct telehealth with their phone, which is amazing because then it enables them to stay in communication, et cetera. Then we do follow-up during and after treatment. So we do blood work while they're on treatment. Sometimes we hold their medication. If they don't have a safe place to store it, we'll give them a week at a time, a month at a time. It's case by case, depending on what their situation is, depending on what their preferences are. I see some things coming in from the chat, and I would love to answer them after I finish. So let's go to the next one. So facilitated telehealth with or without on-site clinician. This is not as low threshold as the telehealth or the Tele-Harm, I should say. This is something that often uses some sort of agency like an opioid treatment program or some sort of agency where they are first identified as, being viremic. Utilizes a case manager or someone on site who identifies that this person is viremic, and then they communicate with the place where the provider is. So they communicate with a care coordinator at the agency where the provider is. So for example, for REACH, the REACH program in Mount Sinai, we have a grant where we collaborate with agencies that are providing rehab. And so someone on site will call our care coordinator and say, on intake, we did labs, this person is viremic. And then we will start to do immediately, we will start to meet with that person, talk to them, find out how long they're going to be at the rehab, get them a phone, make sure that we stay in touch with them, because often they transfer to long-term rehab. So we want to make sure we don't lose them. And then the telehealth, visits can start, the ordering of medication can start, et cetera. Most of the time it is without an on-site clinician, meaning that I am conducting the telehealth with assistance for someone on site, like a counselor, or someone will put the person in front of a computer, et cetera. But I'm less likely to collaborate with an on-site clinician. Blood work can be conducted at the rehab, which is extremely helpful. We can order the blood work, ask them to do the special, Hep C blood work that we need. They can do the blood work there. Then after the telehealth, I can order the medication. Our staff will deliver the medication to the rehab. And if need be, they will be there to set up a, visit if that's necessary. And we will continue to communicate with the person while they are getting treatment. And we will follow them wherever they go. If they go home, they go to long-term rehab, et cetera. So here's another nice flow chart. So people are identified not, by DBS or, it's usually a standard HCV RNA because it's intake blood work, usually at some kind of rehab. So they are referred to the REACH program. Then the REACH program quickly jumps into high gear to make sure that we have all that we need with that person, communication, paperwork, explain to them that we will follow them. First telehealth visit happens. Then we also do the Prep C just to make sure this person is ready for treatment and also answer questions, provide information. There's still a lot of misinformation, not surprising, about interferon. And, I still get questions sometimes about medication being toxic or it being dangerous, et cetera. So we clear up some of the, myths or misinformation. Then medication is ordered and we try to get the medication as quickly as possible because sometimes when they leave the rehab, we might lose contact with them. So we try and then start treatment, post-treatment follow-up at the long-term rehab or maybe back in their home. Sometimes they might actually come to our clinic. If they're back home, then they might come to our clinic in East Harlem. A little bit about the REACH program at Mount Sinai. It is a patient-centered harm reduction approach to primary care. So it is, its focus is primary care, but because we focus on people who use substances and individuals living with HCV, we are very understanding about the consequences of using substances and do it in a very non-judgmental, supportive framework. We're co-located within Mount Sinai's Hospital Internal Medicine Associates on East 102nd Street. So we collaborate with the telehealth provider, meaning that the telehealth provider is collaborating with the person in the rehab with no on-site clinicians. So there is no person at the rehab that is overseeing the care. It is our providers that are doing the care from a distance with the help, of course, of the whole care coordination team. Care coordination team oversees if extra blood work needs to be done, communicates with the phlebotomist or the counselors. We try to stay in touch to make sure that they get their phones, that we know where they're going. We get paperwork signed to make sure we can follow up. All bills, all the billing is done the same way it would be if the person was inpatient. not inpatient, but at our clinic. There's no shared medical records, so electronic medical records. We are using the same medical records, Epic, that we use at Mount Sinai. The people at the rehabs do not have access to our medical records, and actually don't need them, because we are the ones who are providing the care and doing all the ordering, et cetera, through our medical system. Next slide. So growth potential, there's a lot of growth potential. We're doing this model both at Vocal on the street, partnering with peer-delivered syringe exchange and doing outreach at homeless shelters and other places, street, et cetera. But more syringe services programs could be doing what we're doing at Vocal or NYC or, St. Anne's. Why not places where buprenorphine is provided? Certainly, if you have people accessing buprenorphine, you're going to have people with Hep C. So, why not do that as well? Now, primary care, now that we have the expanded definition for screening, it would be very important to provide it in primary care, for primary care providers to ask a few questions, to assess people for risk, whether they might be exposed to hepatitis C or not. Assisted living facilities. I know a lot of us think only about older, and yes, we have the baby boomers who have Hep C, but people go to assisted living even as young people sometimes if they're there for an orthopedic reason, they've had recent surgery. So, younger people can be assessed at, different types of living situations that might not just be for elderly people. Certainly the correctional setting, whenever you look at the maps of New York City and you see the burden of Hep C, Rikers jumps out at you. And yes, they do a great job of treating Hep C, but that is not true of other facilities, across the nation. So we could definitely improve on working with people that are in correctional facilities. And then non-traditional settings that serve the homeless population. I heard Colleen saying we're really trying to be innovative. The people are there. We're just not going where they are. So let's go where they are and, bend ourselves to try to provide treatment for these people. Let's keep going. Sustainability. So this slide looks more at the challenges, and there are challenges. I don't want to be Pollyannish. There are, for sure. So patient needs, if someone doesn't have food or isn't homeless, or obviously their addiction is their number one priority, of course, then, we address those issues. We try to help people. But there's people at Vocal who I'm about to treat now who have been part of Vocal for 3 or 4 years with Hep C and are finally ready, which is great. They needed time. Now they're ready to get treated. We're still here. We're ready to go. Financial considerations. For some agencies, they don't have care coordinators. They don't have peers. They don't know how to cover billing for the very important role of that these people provide. So yes, that's a big issue. And I do know Colleen and all the folks at the state are always looking, like with the Innovative Models Grant, of ways to fund people like that to be able to do all that work. Staffing requirements, for sure. Whose responsibility is this? How does it get divided? And, that can be challenging when it wasn't something that was originally part of someone's work, and now it's a new thing that's getting done. That can be difficult. Infrastructure. So yeah, of course, we need Wi-Fi, we need technology. We give out phones to our participants. They do get lost, they get broken. Sometimes even at the rehabs, sometimes we have trouble connecting. People can't get the video working, can't get the audio working. These are challenges, and sometimes there's frustrations. And then there's physical space. Sometimes it's very hard to find a private space to be able to talk to someone. And some of the questions that we do ask people about their past can be stigmatizing, and you would prefer, all of us, if we had a private space and some dignity to be able to conduct our work. Okay, so summary. So practical guide. So, the telehealth toolkit is really there to be able to give a how-to and to give different models to be able to support both traditional and non-traditional settings. And really, we presented some, but you use your imagination with what your setting is. We just suggested some, but it's limitless depending on, do you have a medical van? Do you park outside of OTPs with your medical van, like Sun River Health? Beautiful. Try to do different models to make it work. Best practices and minimum requirements. When we say minimum requirements, we're also talking about clinical. The original standards for treating Hep C have really been, simplified, which is great. They could even be simplified further, and still we can achieve a lot of cures. Billing considerations, that's a challenge for sure. And then we also have frequently asked questions for people that are trying to just start this up, and how do you do it, and how does it, get to be a new program. Okay, so I see there's a lot of questions in the chat. I don't know how we're going about answering these.
Hey, Abby, this is John Stockton. I can absolutely read some of the chats. I've been kind of keeping track of the questions. So if you'd like, I can go ahead and read those questions for y'all. And at this time, if anybody has any additional questions, you can feel free to put in the chat, or go ahead and unmute yourself to ask questions as well. So the first question is from Rachel, McLean in California. Have you had any challenges with managed care plan requiring a referral from the PCP to a specialist? And 2, dispensing meds and NTPs not licensed to deliver primary care. Those have been some of the biggest challenges that they're experiencing in California.
So that is probably an issue that really varies state by state. And, I have to say we're very lucky here in New York that doesn't happen very often. Once in a while, we have insurance that requires a referral from a primary care provider. But, luckily we have the REACH program at Mount Sinai. And so sometimes very rarely we can have the person become our patient at primary care and then treat them that way. But I have to say in New York, that's not a huge problem. And there was a second question. I'm sorry, I missed it.
There was. And was there any challenges for dispensing meds and NTPs not licensed to deliver primary care?
No, that wasn't a challenge because they're not providing the care. We are.
Gotcha. Okay.
So we might deliver medication to them, but they are not the ones who are providing the care. They're the conduit. They have the person that needs to get treated, but they are not the ones who are providing the care. So it's all us.
Great. Thank you. And the next question is with the the next question is with the telehealth and leveraging DBS, are there any other tests that you are having to do or collect for? Our partners are struggling to justify DBS if the client still has to go into the clinic for more blood work.
So it is hard to get the additional blood work. So when we do the Tele-Harm model, we've done the DBS, and a few times people have said to me, well, I did the blood work already, And so I'll have to say to them, yes, you did do the blood work, but that only identified that you had Hep C. Now I need to do more blood work that's specific to your liver. So it's not easy, and it'd be great to do all the pre-treatment labs and get it all done. But until we know they're viremic, we're not going to check, their liver status. We're not going to do, these other labs. So, there's no shortcut. Unfortunately, one thing I really look forward to is the rapid HCV RNA, which I know Francis Collins and with, the Biden and Harris are really trying to push the point of care HCV RNA. That will help, because then we could do all the labs at once right there and then. We know they're viremic, we have them, and then we can do all the labs, and that would be amazing. But the labs have been a barrier with some of the people who I work with at the syringe services program. It has been a barrier for sure.
Sure. And I just saw that Colleen put in there that DBS is conducted by the New York State Department of Health lab free of charge. Isn't that wonderful, Colleen?
I should have mentioned that. I'm sorry, Colleen.
Yeah, I was actually going to ask a couple things about DBS. One, the turnaround time to get those results back, and two, to let folks know that there is other options for DBS molecular testing labs in Vancouver, Washington right now. I believe is the only one that we know on the West Coast that's currently offering these services for states for a fee, though.
Yeah, the turnaround time is very fast, and it's electronic results. So, it usually comes back like in a week, pretty quick. And so we don't usually lose people, that quick. And we are able at Vocal, where we have a very low threshold, street-based model. We deliver results, I'd say, in the 90% range. So we don't lose a lot of people, which is fantastic.
That is fantastic. That's very that's actually very high. That's great. That's fantastic to hear that. One question too is, what incentives do you provide? Do you do bus passes, food voucher, any kind of gift cards, or just kind of curious about what type of incentives that you're currently using?
Yeah, so we can't give cash, so we can't give like a American Express card. So we give gift cards, and most people have said in New York City, they like Target. So we give Target gift cards just because you can literally buy anything, food, clothing, anything. And there is a Target that's walking distance to our brick and mortar in Brooklyn. So that's usually what we give. We do give Metro cards every time they come for a visit to see us. They get Metro cards, and often they get food as well. Not vouchers, but actual food. When they come into Vocal, we have food and coffee available to people for sure, and clothing, and a shower, and a washer dryer.
That's fantastic. Do you guys also have any kind of med lab, a way to store the medications also on site?
Yeah, so we don't have our lockers up yet, but that is going to be the plan, is to have lockers on site. And so people will be able to walk in and just get their medication, when they want to, privately in their own locker. So that is in our plans.
That's great. That's great. Another question that came through the chat is, I'm curious as to why the psych readiness appointment is a second telehealth visit and not part of the first telehealth visit.
That's a good question. So the reason why it's a separate visit is because it's not usually conducted by the provider, the NP, the PA, or the MD. It's usually provided by the care coordinator or the peer, the other person. So, sometimes those are done separately, but, because it's a lot to do all at once, both the initial visit and the kind of readiness. And usually the readiness happens first before the initial visit to make sure that we can go forward.
That's great. Thank you so much. And the next question, and also there's a comment kind of tied to this. One of the things that I'm hoping we learned from the horrid COVID-19 pandemic is that we need to incorporate multiple flavors of prevention and intervention into healthcare encounters with resilient and traditionally oppressed communities. Can you speak to the vaccine work that you do that may be braided into the breadth of this work you are so beautifully describing?
So in Vocal, we don't do any vaccine work right now anyway. We don't have vaccines on site. I know other health, clinics that are affiliated with syringe services programs do. Certainly the REACH program at Mount Sinai provides all vaccines, COVID, hepatitis A, B, flu, you name it, because it's, in a outpatient, primary care clinic. All vaccines are provided on site.
Great, thank you so much. And the last chat question I see here is, what is the frequency that a care coordinator is able to visit a given site, like a shelter or an SSP, to offer services, or is the care coordinator a staff member at that site?
Good question. So both are true. We have care coordinator staff at Vocal who are on site in our syringe services program, and they are there. So people come in if people need help with health insurance or getting to an appointment or making an appointment, all of that can happen on site at the syringe services program. In the REACH model, our care coordinators actually go to the rehabs and to the OTPs on a regular schedule. So every week, our 2 care coordinators will go to each of the rehabs or the clinics, on a regular schedule. So for example, this morning I did a couple of telehealth appointments, and the staff members, the REACH staff members, were with the people that were getting treated for Hep C, setting up the visits, sitting there for support, bringing medication, bringing phones, getting paperwork signed. So they go to where the participant is.
Great, thank you so much. And it looks like another question popped in. It says, how are you going about completing the patient assistant program applications through telehealth if the client is unable to sign the patient assistance application themselves? Also, are you using the online version of the patient assistant program applications? If yes, does that have to be a prescriber, or can it be a nurse or other clinical staff member?
So I guess I'm not clear on what patient assisted program is. That just like the registration paperwork? Is that what that's referring to?
So my understanding for I believe this is for the patient assistant programs to help offset the costs from the drug manufacturer. So patients
Are you talking
able,
maybe? Oh, so you're talking about like the HepCap program?
I
Or,
believe so, yes.
okay. So the HepCap program is available for people that might be undocumented and cannot access Medicaid or public insurance. And so our care coordination staff will fill out the paperwork to support PATH with Gilead to provide the medication for free. And that is something that Gilead makes available. So the paperwork is, filled out by one of our staff members, our staff nurse. And then that paperwork can be brought to wherever that person is, if they're at a rehab, and they will sign, or if they come in person to us, they will sign that paperwork, and then Gilead will send the medication free for that person, and HepCap will cover the cost of the medical visits. So the person will pay nothing.
Great, thank you. And I was wondering if there was any unintended costs of doing this. Was there anything that popped up that you didn't intend, or was there any type of technology or any costs associated with technology as you were setting this up?
So, we buy very cheap phones because they get lost frequently. So that, we didn't expect the phones to be lost or stolen or damaged quite as often as they are. But because they're very inexpensive, that's not too bad. But it is a lot of busy work because you have to maintain the service. So then you need to know whose service should be maintained, who shouldn't. And that's what it is expensive, is paying the monthly service. So it's not a huge expense. And honestly, with people living in shelters, living on the street, et cetera, we anticipated that things would get lost. But in terms of technology, a phone is all you need. We don't need sophisticated or complicated technology.
Well, that's refreshing to hear. And another question popped in about how long is the wait time between returning RNA results and having a telehealth appointment? It sounds like maybe it's the same day.
I wish it was the same day. That's what we're looking for with the Cepheid machine, to be able to do that the same day. If it's at the REACH program, when we're doing in-house blood work at Mount Sinai, it's very quick. It's a couple of days. The RNA will come back. If we're going to LabCorp, it's a little longer, but either case, it's definitely less than a week. And then we quickly try to communicate with the person and get it moving. So, but usually the telehealth takes place first, and then we might order the blood work. Sometimes we have the HCV RNA ahead of time, and then we have to order the rest of the blood work. So it depends on the situation, but either way, it's not a long wait to get the blood work results back.
That's nice. That's great. And I'm curious if you guys are doing any kind of evaluation of this using telemedicine versus maybe the traditional care models for this actual program.
There is an evaluation with the REACH program. There is evaluation of how the grant is going. I can't speak to whether it's comparing to our traditional model, because I honestly don't know if that level of research is being conducted, but we are always gathering information and analyzing and looking for ways to improve our treatment outcomes.
Right.
John, I will say for our innovative models of care, which Abby's the VOCAL program is part of. So our innovative models of care are co-locating Hep C treatment in non-traditional healthcare settings, which Abby is part of that with VOCAL. We also have another Montefiore Medical Center in New York City is co-located at On Point, which is our overdose prevention center. And then we do have another provider out on Long Island who is providing Hep C treatment mainly through telehealth to clients at methadone programs. And we do have a comprehensive evaluation of those three models happening right now. It's a collaborative with the UAlbany School of Public Health. So we will have quantitative and qualitative data to evaluate those models. Sun River on Long Island is also providing treatment via mobile van as well. So we'll be able to look at co-location at syringe exchange programs, telehealth, and mobile van.
So I'm always impressed with what New York is doing over here in Washington. Curious what the client feedback has been about this.
Well, that's a good point. And actually, sorry, Colleen, I didn't mention about UAlbany before, but so UAlbany has interviewed both staff and participants, and that will be part of the qualitative data for sure. And, I can tell you that the people that they have interviewed so far in VOCAL have really loved getting treated in this way. Some of these people have tried to get treated in a more traditional manner in the past and were not successful. And so I think having it co-located, in a low threshold setting has, really increased the desire and efficacy of getting treated. So far it's been very, very positive. And people have really been happy to be able to get treated where they're going anyway.
Absolutely. Well, are there any other questions from the group? I want to thank everybody for their questions in chat.
I think my colleague Jeff Weiss just put something in the chat, but I didn't see it. So maybe you could read it out.
Sure. So Jeffrey says, I work with Abby at REACH. The patients we are treating at inpatient detox rehab programs have many more challenges than those we see at the REACH clinic, so not really comparable groups. Those at inpatient detox rehab are much more likely to be straight homeless and disconnected from healthcare.
And that is true with the people we see at VOCAL as well. And because of that, there is a lot more care coordination and pre-work, I would say, that needs to happen. And that it obviously can impact the numbers that we have of people that actually get treated. But what you're doing for them while you're getting them ready for treatment is very important, work, getting them health insurance, getting them more stable. So, we can't just keep our eyes on HCV treatment. We also have to realize that HCV treatment can actually be a gateway to improving their lives in a lot of ways.
Yes, absolutely. And another question popped in. What proportion of loss to care are you seeing, and how do you re-engage those participants?
You know, I don't have a statistic off the top of my head, but it's common, especially with the folks in rehab, because they're only there for 28 days and they leave AMA, and then we have no way to find them. Same thing with vocal. They're living on the street and sometimes we can't find them. We go and we look, and it can be challenging, but we stick with people, and sometimes they appear again at a rehab, and then they come back and they're like, I want to do this time. So, you know, we keep the feelers out, we keep in communication, and it happens that people we lost, we get reacquainted with, and then we treat later.
Great, thank you. Some more questions popped in. One is, how do you handle more complicated cases like cirrhosis or co-infection?
Good question. So we're very lucky at Mount Sinai that we can partner with the Institute for Liver Medicine, where they have a FibroScan machine in the same building where REACH is located. So if the person is, you know, in clinic, we can walk them upstairs for a FibroScan. We can schedule an ultrasound. We can have the hepatologists, you know, help us. But, you know, depending on their cirrhosis, if it's not decompensated, then, you know, they can still be treated with consultation with the hepatologist. So we're lucky that we have someone to talk to, but just because they have cirrhosis, it doesn't mean that they're out of luck to get treated, even in these low threshold models.
Great. And the next question is there a limit to the number of people that you can treat on patient assistance programs that you know of?
Support path, there's no limit as far as I know. You know, we don't get a lot of people, but I've never heard them say you have too many, or, you know, not that I know of.
And next question is, were insurers initially comfortable with paying for this program, or did it require negotiating with them to persuade them that this was an acceptable service to bill for?
I think that's Colleen's domain.
So there was a lot of, you know, there's a lot of guidance put out during COVID about telehealth. And when we were, you know, in a state of emergency in New York State, new guidance was just issued. I can't wrap my head around all of the guidance related to telehealth and billing. Obviously, it's not my area of expertise. I think there are some things with the federal emergency going away that there may be some concerns about. One thing that was great during COVID is that requirement. There was not that requirement for an in-person visit, for at least one in-person visit. We hope that that does not go away, because the in-person visit sometimes is a huge problem. So I think we're still waiting to see and for the dust to settle once the states of emergency and the federal emergency goes away. But telehealth is billable. And so, and I think there are some things that we learned through COVID that were very valuable that will stick around. But I think we have to wait and see.
Great, thank you so much, Colleen. Well, I think we're just about at time, and I believe I need to hand this back over to NASDAD and say a few closing remarks. But I really want to thank Colleen, Lauren, and Abby. Fantastic work. This has been really, really comprehensive and fantastic. I love the workflows because I'm very much nuts and bolts myself and how to implement these kind of things. So thank you so much for your presentation.
Thanks, John.
Thank you.
Yes, thank you all so much. Yeah, this is definitely a nuts and bolts group, and that's obvious from the questions that you all had asked. So thank you again so much for our panelists, and also for John for moderating the discussion today. I just want to let you all know about our upcoming sessions. On April 19th, we have a session on categorizing hepatitis B mortality and considerations for health departments in analyzing cause of death data. And then on April 26th, we have the Hepatitis C State of Medicaid Access 2023 report card update with MVHR and the Center for Health Law and Policy Innovation. Also, these are just presentations. We don't have the follow-up breakout sessions. But we are glad to have you all and hope y'all can join us for these sessions. And I don't know, just want to say thank you again to our panelists for this great information. We will make sure that we share all the links with you all. And y'all have a great rest of your Wednesday. Thank you so much.